Hey everyone, and welcome to our video on urinary tract infections. So these guys are pretty high yield when it comes to the renal system, mostly just because they're quite a big problem. They happen a lot, and they can. There's a lot of very common reasons why they might happen. So we'll go through them. We'll try and cover the most high yield parts in particular, and hopefully you guys have a better understanding of UTIs. So let's first talk about how it actually happens. So the general idea of UTI is that, as you might expect, you have bacteria in the urinary tract which have established themselves. So usually these are gastrointestinal tract bacteria. So we're talking about gut bacteria that have found their way into a new area. Obviously, in the gut, they're often not much of a problem, although they sometimes can be. And then in the urinary tract, because it's a different sort of environment, they can then become a much bigger problem. Okay. So technically a urinary tract infection can be present at any part of the urinary tract. And the main distinction that we draw is between the lower urinary tract and the upper urinary tract. We'll talk a little bit more about that later. So it's not necessarily all the way up into the bladder. That's just sort of part of the standard definition. But we can definitely have colonization only of the lower urinary tract, i.e. the urethra, and then get symptoms from that and obviously have a disease. So in terms of risk factors, you may already know that they're much more prevalent in females than males, and that's mostly due to anatomical differences. So the female urethra is shorter, which means that there's less space that the bacteria has to climb up before it gets to important structures like the bladder, where it can establish itself. And it's also closer to the anus, which just means a physical, on a physical level, it's easier for the bacteria to get from where they're coming from, the gastrointestinal tract, which is not at all sterile, to the urinary tract, where we want to at least try to keep harmful bacteria out. So the vesico-ureteric reflex, depending on how much you know about the anatomy of the bladder, you'll be able to remember that there's two places where the ureters actually meet the bladder. Now, those are meant to be one-way valves that only let urine down and not back up. If they do let urine back up, you can have problems with hydronephrosis, which basically means there's a bunch of urine which is meant to go down. The kidneys are not meant to hold a bunch of urine. If you get too much backflow, you can cause the kidneys to really swell up and the ureters as well to really swell up. And that is very bad for your kidneys. So that could be primary, which means that they have a developmental abnormality, or it can be secondary, which means we can get basically due to anatomical changes. So it's important to understand the distinction. If it's primary, they may have normal bladder neck or urethra, and it's simply a problem with the junction. They may congenitally have a small bladder neck or urethra. And then in secondary cases, there's something else that's causing a stricture, as we call them. And of course, we want to be considering those in recurrent UTIs, because these are sort of over and above the other risk factors. Urinary tract obstruction, which is pretty self-explanatory. Pregnancy, neurological pathology basically means if we have trouble properly voiding the bladder, then we are taking away one of our big tools to prevent colonization of the urinary tract, which is that sort of constant flow of urine. Prostatic hypertrophy, which you might soon learn about, is BPH, which is basically causes a urethral stricture, and then a few other issues. Malignancies, i.e. prostate cancer, can do the same thing. Catheterization is a really big one, and this can be almost pathognomonic sometimes. If they give you a case where somebody has been catheterized in hospital for a while and they're now reporting sort of fevers and chills and flank pain and all that sort of stuff, then obviously we might want to consider that, and diabetes mellitus. Okay. My slides are not working together. Okay, perfect. So in terms of causative organisms, E. coli is by far the biggest group. You can look at the graph here. It's biggest in community acquired by a wide margin. It's still biggest in hospital acquired. There are a couple other ones that are useful to know, mostly because of their sort of interesting manifestations. So Proteus mirabilis, it sort of causes if you guys have done chem, it causes precipitation of various acids out of the actual urine, which means that we get urinary stones after a while. And so it can present with both urinary stones and an associated UTI, having caused both of them. Staph saprophyticus, that one's called honeymoon cystitis, which is basically young sexually active people end up getting it. In hospital, we are particularly concerned about gram negatives. And so you can see they make up quite a big portion of the nosocomial graph over there. And then there are a few different ones. Very rarely, viruses and parasites can cause UTIs. So in terms of virulence factors, i.e. things that the bacteria have that make them more effective. So E. coli has, in some ways, it's actually very well suited to the urinary tract, which is why we get so much infection. So it has what we call fimbriae, which are basically little spikes that come out from the bacteria, which is sort of like a little pill-shaped thing. We have little spikes that come out and they actually help it stick to the bladder wall. There can also be little antigens on their capsule. So if we remember talking about that sort of typically carbohydrate shell they have around them, they have a little antigen which makes it harder for phagocytes to eat them. And then they sometimes also release hemolysin, which can cause damage to cells in your kidneys, basically. Okay, and the capsular polysaccharide antigen can also cause pyelonephritis. So basically, the upshot is that it can do a lot of bad things to your kidneys in its job to attempt to stay undetected and undestroyed by your immune system. Sorry, can't speak today. So Proteus mirabilis, as we said before, it pumps up your production of urease, which means that your urine gets more alkaline. Usually it's more, obviously, usually the balance is going to sit more acidic than if we pump it up. And then we can get both renal stones. So kidney stones, really, really big issue with these because of the increased production, and then also pyelonephritis. Yeah. Okay, so in terms of clinical presentation, please learn this. I'll put 3 stars on this one because it is really, really high yield. I've bolded each of the important bits in the upper UTIs and the lower UTIs. That's not to say the non-bolded bits aren't important as well. So they are also very relevant, but basically the bits that will help you differentiate the two presentations. And I should have bolded fever on the left. I'll do that in the slides when I put them up. So in terms of upper UTIs, you, with both types of UTIs, will get bacteriuria because you've got bacteria in the urinary tract. You'll get hematuria because you're getting damage to the urinary tract. You'll get pyuria. In upper UTIs, the typical associated symptoms would be fevers and chills because this is sort of a more, I don't know if serious is the right word, but it's a more central infection. You get back and flank pain because we're dealing with the ureters and the kidneys, which refer to your flanks and your back very commonly. You get nausea and vomiting, which you don't usually get in lower UTIs. And that sort of trio, back and flank pain, fever and nausea and vomiting, is a really good sign for UTIs. And pyelonephritis, which is basically something that happens in the first place. It's important to consider, not a very common presentation, but certainly it's something that can happen. You can get what we call hematogenous pyelonephritis, which basically means that your kidneys are getting inflamed because of something in your blood rather than something in your urinary tract. And that can present a lot like an upper UTI. So I think it's very rare that they'll throw something at you where it is hematogenous pyelonephritis, but it is something to keep in mind. And then in lower UTIs, really the most common sort of symptoms and the ones that are almost pathognomonic for lower UTIs are dysuria, frequency, suprapubic pain, and urgency. Okay, the first 3 most commonly. So if you see those those 3 in a female patient, it's very, very, very likely that they've got a UTI. So we don't usually expect a fever because it's only in the lower urinary tract, and you can also get cloudy or smelly urine. Okay, so dysuria and frequency can also happen in upper UTIs, but they're just very, very significant and very, very common in lower UTIs. So please learn these because they will come in useful in your exams. Okay, so atypical clinical presentations. These ones are not as high yield for you guys, but it is good to know. So with infants and young children, a large part of it is basically just the fact that they can't tell you what's wrong with them. So a lot of things that would be reported normally with symptoms, things like dysuria, frequency, all of that. Dysuria is going to present as crying on urination because they can't tell you that it hurts other than by crying. We already talked about cloudy, foul smelling, or red, i.e. hematuria. irritability, vomiting, and food refusal. So it's all just signs of mood disturbance, basically. And so, yeah, that's sort of the challenge with very young pediatrics and work with infants, because they just can't tell you what's going on. In the elderly, this is a little bit more for upper UTIs, because they're, again, more systemic almost. And basically, we can get a whole bunch of mental disturbances. So hallucination, social withdrawal, agitation, confusion, restlessness, all of that sort of stuff, because basically the side effects of just having a significant infection. Pregnant women can also present a little bit differently. You don't need to know too much. Indwelling urinary catheters, for those, a lot of them do present fairly normally. So I wouldn't worry too much about just going for the diagnosis if that's what it's shaping up to look like. Okie dokie. So you have recurrent UTIs. These ones are, I forget the definition exactly. I believe is multiple times in 6 months, but I may be wrong. And we sort of want to draw a line sometimes between the same infection recurring, so same organism happens almost immediately after they finish antibiotics for the first infection. And so that might just be some of the organism surviving and reestablishing itself. Whereas different infections, so different organism often, and it happens with a significant break. So we're looking more at the latter type. So i.e. they've had a UTI, it's genuinely gone away, and then they've had another UTI. And basically we want to know why, because normal people don't get that. So in men, you want to look at prostatitis, i.e. prostate inflammation, or benign prostatic hyperplasia. In premenopausal females, you want to inquire about their birth control. So spermicide diaphragms or spermicide condoms can cause forms of UTIs. If they had many childhood UTIs, then you maybe want to look at birth defects, i.e. developmental abnormalities of the urinary tract. And also childhood UTI in of itself can be a risk factor for later UTI. And then also sexually active. In postmenopausal females, you want to look at the idea of a prolapsed bladder, which is quite nasty. Also, just looking at the different symptoms that you're likely to get there. So incomplete voiding. So like we said before, this is sort of tying into those neurological issues. If you don't properly void all the urine, then you lose that flushing ability of the urinary tract, and that can let bacteria sort of fester. Past UTIs, again, just a risk factor, and urogynecologic surgery, like a hysterectomy or something, might be a potential risk factor. Okay, investigations and diagnosis, very, very important. So the midstream urine is one of our favorite little samples. In general, you just want to take a urine sample, and MSUs are really, really useful. So this is sort of more for, later on when you're trying to explain this to patients, but you want to stress to them that it's not you start and then you sort of hold it and stop and then you position yourself and then you take the sample, because then you're just getting a new beginning stream urine. It needs to be actually in the middle of a stream, so there can't be any stopping, because every time you stop, it loses the midstream quality, because basically the idea with midstream urine is we don't want to catch stuff that's right around the very end of the urinary tract. We want to catch something that's actually in the urine, if that makes sense. Babies and young children, that can be quite difficult to get them to do. So you want to sometimes take bag urine. If they've got a catheter, you can just take the samples from that. A suprapubic aspiration is basically taking a direct sample from your bladder. So that is typically sterile, which is good because it will help you actually make sure that the thing you're finding in the urine is actually an infection, whereas midstream urines may not be. But that's also got a risk of obviously infection, because it is an invasive procedure unlike the rest. We want to take these before we start antibiotics, because otherwise, we're just sort of shooting in the dark. And then we want to culture them. So the tube that we typically use, so we get blood agar, which either grows gram-positive or gram-negative. So it won't differentiate those, but it does show you if you get hemolysin, which, as we talked about, is a risk factor, or not a risk factor, but a virulence factor in E. coli. And then we also want to we also sometimes culture it on McConkey medium, which is good for identifying gram negatives. Like we said, those are a pretty big deal in the nosocomial setting, and also we have E. coli growing there. Now, the bit in orange I've highlighted because it is important. So the threshold we want to care about is more than 10 to the power of 5, i.e. 100,000 colony forming units, sometimes written as just CFU, per milliliter, okay? And that's for non-sterile samples. So your midstream urine, if you get more than 10 to the power of 5 CFUs per milliliter when you culture this, then that's basically enough bacteria to say this is probably an infection. The threshold is lower if it is sterile, i.e. a suprapubic aspiration. Beyond that, there are a few different things we can do. So we've got a urine dipstick, which you guys might have learned already or be learning soon. So basically, if you get blood in your urine, which the dipstick can detect, if you get white blood cells, that's obviously really, really good for infection. Well, a good sign for infection, not good for the patient. Nitrates can also be good. Problem with all of these is that basically it could be a whole bunch of different things, including, up to including contamination of the sample. So it's not super specific, is basically the problem, although it is fairly sensitive. So blood test, you do this if they're particularly unwell, and within up to UTI, they'll probably be febrile and potentially quite unwell in the first place. And again, that's looking at white blood cells, CRP, which is a marker of inflammation, and then your blood culture. So again, if it's a low urinary tract symptom, if it's a lower urinary tract infection, there's a chance that won't give you anything. So it might not be a useful test to do because it's just not close enough to the actual bloodstream. If it's the upper UTI, then this can be a really good test. And then we can do an ultrasound of the kidneys or bladder. We can do a voiding cystourethrogram, which is basically just watching things as you void, which is very geared towards incomplete voiding, congenital abnormalities, and that sort of thing. And usually you do those in children with UTIs. So if they're less than 5, if they're male, if they typically get febrile, they have a fever during the UTIs, or if they just have recurrent UTIs. So those are all risk factors that when you see a UTI patient with those, you're like, oh no, I need to check up and see if there's something going on with the anatomy. Okay, and then now finally the management. So if we get just a bog standard UTI, often, because it's so linked with bacteria, we're going to probably default to antibiotics. So you take oral antibiotics for 3 to 5 days, and that should usually kill all the bugs. If we get something more significant like pyelonephritis, so this patient's come in with, back and flank pain, they've got a fever, they've got chills, they've got night sweats, then we want to start them off on oral, we want to start them off on IV antibiotics, and then we want to transition them to oral antibiotics and go for a course of, about 2 weeks at least. And of course, that's going to be reviewed when we come back, because we don't just stop if they're still having symptoms after 2 weeks. So fortunately, pyelonephritis isn't usually a condition with very significant complications. If there is currently existing renal dysfunction, or it happens again and again, then we might start getting worried about complications. And then in order to check whether the bug has properly disappeared, we would do a culture of something like an MSU. And then in terms of prevention, so drink lots of fluids, don't dehydrate yourself, which is also good for other symptoms like kidney stones as well. With cranberry juice, we have evidence for it helping. No idea why, I could not tell you the mechanism. Wiping front to back. So if you wipe back to front, you're basically inoculating all of your urogenital area with GIT bacteria, which is very bad because they're not supposed to be there. Voiding urine after intercourse, so that's a case of basically, again, the same thing, just infection control, and using that sort of inherent flushing capability to try and move them out. Avoiding spermicides because they're a risk factor. If we get recurrent UTIs in a postmenopausal female, then sometimes we want to give them topical estrogen or probiotics because we think it might have something to do with their natural biome or potentially their hormone levels. Sometimes we want to give them a prophylactic antibiotic. I don't know how it got to remented. That's meant to be remember, the antimicrobial code. And basically the idea is, we have a lot of problems with resistance. The two main drugs that we actually use for UTIs, which you probably don't need to know, are trimethoprim and ciprofloxacin. And both of those are starting to run into issues with resistance. So we want to really be careful with using antibiotics. We don't want to create more resistant drugs that are then going to cause us problems down the line. Okie dokie. That one was a little bit on the longer side. Hopefully you guys felt like it was a good overview. If you have any questions, feel free to message us. But otherwise, have a good day.